Health Coaching and Beyond, Tim and I aim to mix up conversations between the two of us, chewing over hot topics, latest news and emerging ideas, but also bringing you conversations with thought leaders and people we admire in the field of health coaching and beyond. People we hope will help you think well and spark interest for yourself. This week I interviewed Professor Sir Chris Ham. What an honour. He's truly been one of my guiding stars throughout my career. His writing and leadership have inspired me and others across 4 decades. Have the chance to hear his review of the position of our current health system and to hear his reflections and ongoing encouragement for health coaching and personalised care was a real treat. We explore what Chris has learned over his 40 years of influencing and leading at the very top of the NHS. Indeed, he's still the co-chair of the NHS Assembly, a core advisory body to the NHS bosses. I hope you appreciate Chris's wisdom and insights as much as I did. So Chris, welcome to Health Coaching and Beyond.
Thank you.
Lovely. It was lovely to have you here. Thank you. And I am going to start, I hope you forgive me, I'm going to give a little bit of an introduction, give listeners a little bit of an idea of the calibre of your background, Chris, if that's okay. So correct me if I get any bits wrong. I've taken most of this from things you've shared with us before and from Wikipedia. Well, maybe we should only have guests that have a Wikipedia page. So, Chris, you began your career as an academic, as a political scientist, and then moved into health policy and management. You were the Professor of Health Policy and Management at the University of Birmingham from 1992 to 2010. During that time, you were seconded to the Department of Health for 4 years in Tony Blair's government to be part of the director of the strategy unit there with Alan Milburn. Previously, you've been Chief Exec of the King's Fund, a really important UK think tank from 2010 to 2018. You've been the Chair of Coventry and Warwickshire Integrated Care System, ICS, and the Non-Exec Director of the Royal Free London NHS Foundation Trust, and an advisor to a range of management consultancies and health organisations. And you're also currently the NHS Assembly's co-chair, which is a really key advisory body to NHS England on implementation and health and care strategy. You've authored over 20 books. You regularly write for the BMJ, the NHS Confederation. And to be honest with you, I've followed your writing throughout my career, really. And you were awarded a CBE in 2004 for your services to the NHS. And you were knighted in 2018 for your services to health policy. Wow. Quite a brief.
You're going to ask me what my first disc is now, are you, Ronnie?
Yeah. Well, we could do so. Wrong show that one, Chris. But we could come back. I don't know. What would be your first disc? Do you have Are you a musician?
Well, I'm not a musician, but I like listening to music, and I've got very eclectic tastes. From classical to jazz to rock to folk. So I'd find it really hard to narrow it down in a desert islandist fashion.
Well, I think that sort of characterizes you, what I've known of you, Chris, and that you've sort of sat, haven't you, for decades at the intersection between a whole load of mixture of things in healthcare, health policy, leadership and real world NHS delivery. And I must admit, what struck me is that you've constantly tried to sort of bridge that gap between policy ambition and what really happens on the ground, what the NHS says it wants to do with what actually happens. And we are at another really sort of important cross-section at the moment. NHS has just written a new 10-year plan. There's an ambition to go big on prevention and community and more personalised approaches. So I really hope in this conversation we can perhaps use you as a critical friend of the moment with all your previous experience and wealth of knowledge to kind of think about what the asks of the system are right now and what the ask of us, people like me and Tim who are trying to enact person-centred care. So maybe I could just start with saying, well, where do you think we find ourselves at the moment?
Well, I think, as always, it's a mixed picture, Ollie. I'd say on the one hand, there's a lot of interest and potential excitement around the government's 10-year health plan. A lot in there to like, but I think it's much more of a prospectus with a lot of ideas put forward rather than a implementable plan. There's a huge amount of work to do to get beyond the ambitions set out there, which I'm sure most of us would welcome and see is absolutely the right way to go. More emphasis on prevention, more care in the community, embracing opportunities around new technologies, including digital, and the reality that we face at the moment, which is an NHS still, in a way, in recovery from the pandemic, with staff having been severely affected by all the pressures involved during that time, and patients still waiting far too long, whether that's waiting for urgent and emergency care, which is in a shocking state, in my view, whether it's waiting to see a GP or a primary healthcare professional, or indeed those 7 million plus people who are waiting for a diagnostic test, an outpatient appointment, or indeed a medical procedure of some kind. So there's a dissonance, isn't there, between the optimism and the ambition around the plan and the harsh reality of both patients and staff on the ground.
Absolutely. Mixed picture completely. And so, I mean, how optimistic do you feel about our chances here? We've got a lot of headwinds, as you described,
Yeah.
perhaps some bold ambitions. How optimistic are you that it's going to be any different this time?
Well, I suppose I call myself an optimist, but a realist as well, if that's not contradictory. I think
Yeah.
optimism is a hugely underrated quality, particularly for people in various leadership roles. Unless you've got hope, unless you've got belief, unless you see possibility, then I'm not sure you can lead effectively. You've got to persuade others to follow your lead. You've got to generate that sense of there is optimism for the future. And so I'm starting from that position, but feet on the ground, we're still a long way away from where we ought to be. And it's taking much longer to recover from COVID and cut those extraordinarily long waiting times. Do much more around quality and safety of patient care. And above all, what we're going to talk about, I'm sure, Ollie, we should see people and patients as partners in care, having a positive role to play alongside the wonderful, skilled staff, clinicians, and others who are there, fighting the good fight every day of the week.
Yeah, that's well, let's get into that, Chris, because I mean, I was really impressed by that paper you wrote almost a year ago now, didn't you? When I know the NHS plan talks about these three big shifts, doesn't it? Shifts to prevention, from hospital to community, and from analog to digital. And you talked about a fourth shift, didn't you?
Yeah, so what I meant by that, Ollie, is that we need to give much more attention, in my view, and I felt this for quite some time now, to what is the positive role that people, patients, service users, family members, all of those people can play in helping to promote better health outcomes and better care experiences on behalf of all of us who depend on the NHS, who've got almost like a love-hate relationship with the
Yeah.
NHS. We love to know it's there for us. We no longer have to be concerned about the how we're going to pay for the costs of care as and when we need it, because free at the point of use has been embedded for a very long time. But we hate it when our experience falls short of our expectation. And I think one way, it's not the only way of bridging that, is what I call the fourth shift. To continue, of
Yeah.
course, to train and support staff to do the jobs that they came into the NHS to do and to make their lives easier. For example, by one of the other shifts, greater use of digital, less reliance on analog technologies, but also to recognize, if you like, the agency, if I can use that word, of every
Yeah, I
citizen
like
in
that
this
word.
country. The decisions that each of us takes every minute of every day, of every week of the year, makes a huge impact on our health outcomes, on our well-being, and the experience we have when we need the professional help of the medics, the nurses, the therapists, and all of the others. And I think for too long, that agency of people themselves hasn't been recognized sufficiently. There are notable exceptions, for example,
Yeah.
around self-management support for people with various chronic medical conditions. I think the experience of diabetes is one that we need to pay much more attention to. People with diabetes, we know, go into remission when they take a lot more responsibility for their own health and well-being, aided by technology, aided by healthcare teams, aided indeed by health coaches, which I know is close to your own heart.
Yeah.
But we have to start by saying, what can each of us do to play our part alongside everybody else? And that's why when I talk about these issues, for me, it's all about sharing responsibility for improving health and delivering the best possible care. It's not about personal responsibility. It's not about, if you like, blaming people when they become ill for the condition they're in. That would absolutely be the wrong thing to do. But recognizing that a key member of the healthcare team is the person who is receiving that care and who will benefit with their agency is recognized alongside the expertise of the highly skilled professionals in the team.
So it does seem so important. Why do you think it didn't make it onto one of the key shifts for Wes Streeting's ambition for the NHS then? Why isn't personal agency and a more of a partnership approach core to the NHS design at the moment?
Well, I wish I could tell you I don't have an inside track on what's going on in the minds of our ministers at the moment. I think you can read between the lines of the 10-year health plan. There are some clues in there that this issue is recognised to be important, that there are various statements about working with patients, patient partnerships, informing patients, seeing technology, wearable technologies so people can monitor their own health and well-being and then act on that accordingly. So I think the door is open. I think it's hard, though, to go down the line of shared responsibility when the NHS itself is in such a difficult position. Maybe as the NHS improves over the coming years, it'll be easier to talk more directly about these issues because the NHS has to play its part in delivering on that social contract, as well as looking to everybody to play their part.
There's a sort of catch-22 here you're describing, isn't there? That actually, if we want the NHS to operate differently, I guess we need to get some of the kind of short-term stuff right. But the irony is, isn't it, is that actually we'll deliver better care as an NHS if we're able to shift this way of thinking. It's that mindset shift. You've written about this, haven't you? Almost a culture shift to recognize that this, sort of proactive partnership approach where we hand over more agency and power to patients is going to work better for everybody. It work better for staff, it work better for patients, but there's a reticence in the system to let that happen.
Yeah, and I think, let me put it another way, because I think we need a bit of optimism here, don't we? Yeah,
Oh,
even if
please, Chris.
these ideas aren't front and center of the 10-year health plan, they're not in every speech every minister makes. What is the NHS? The NHS isn't some monolith where everything depends on the ministerial team in London deciding this is the right thing to do, and then it happens. The NHS is made up of, 1.5 million staff. When I came to
Yeah,
join the conference in Sheffield in, when was it? Back in May, June time, a lot of other
yeah,
people
June.
there were absolutely persuaded this is the right way to go. So what we need, I think, is to try and generate what I might call a social movement for
Yeah.
shared responsibility, a social movement for recognizing the agency that every citizen has around health and care. We can't wait for the politicians to wake up and see this as a very high priority, but there's nothing stopping us doing it in our own communities.
Yeah, and I like the optimism. And I think, with you having been a observer of policy over these decades, I wonder what you think about, there is that element, isn't there? Let's just do it. Let's not wait for the policy advisors to sort of give us permission or to give us funding or resource. But nevertheless, there's always some sort of greasing of the wheels that needs to come from policy. You need to know that you're going to be supported if things go wrong. You need to know that, because they inevitably will go wrong sometimes, won't they? I don't
Yeah.
know. What how much role do you think policy has in making these things happen, and how much is it bottom up?
Well, it is important, but it's not the be all and the end all. I'm in the kind of beg forgiveness, not seek permission school of thinking. Let me give you a concrete example. I spent a day, a couple of years ago, it is now, down in Frome in Somerset with
Yeah,
Helen Kingston, who is the lead
yeah.
GP in the Frome medical practice. And I know you're aware of this, Ollie, but some of our listeners
Mm,
may not be. Frome is a small market town serving in the medical practice virtually the whole population. It's just short of 30,000 people. So you can imagine the size of the medical practice. Very fortunate to work out of a lovely new building where they're co-located with some of the specialist services. So Helen Kingston, the lead GP, and her colleagues uh, decided, where are we now, 2025, so this is over 10 years ago, they wanted to
yeah,
change their model of general practice. They could see lots of assets in their community, the voluntary sector, volunteers of different kinds, and they wanted to harness those assets in terms of improving the health and the experiences of the people that they were serving. And it wasn't a national policy, and they didn't ask permission, they just got on and did it. They needed a little bit of funding, but it was tiny sums of money by comparison with what typically we spend on the NHS in a community like that. They were able to employ a small number of new staff. They also were able to draw on an extended network of people in their community. These were people in the community, that had a variety of different roles. They could be postmen and postwomen. They could be taxi drivers. They were people who would signpost sources of support and help to their neighbours, their friends, or people that they were actually serving in their professional roles. And that way they were able to draw on far more than just what was in the practice. By keeping in close
Yeah.
contact, they were able to anticipate the needs of that population and support people much more effectively. But also, they may not have used the word agency, but they certainly, if you like, tapped in to the contribution that all of their patients could make to the task that they were engaged in. And, I just so impressed with what they did literally on a shoestring. And,
Yeah.
nobody told them not to do it. So they got on and did what they felt was the right thing for their community.
Yeah, absolutely. And like you say, they had that belief in the value of pursuing that agency and doing things a bit differently, I guess. And I know you've written extensively about systems across the world, haven't you? The Kaiser system in America. You've been over to the Canterbury system in New Zealand. You've what what's the commonalities then, Chris, where people do innovate and are successful? Is it down to leadership? Is it just being brave enough to go against the dominant paradigm? What are the features you think that enable these things to happen?
Well, I think we need clinicians to show the leadership here too, in the way that you are and other colleagues around the health coaching work that you're involved in. So I'll give you two specific examples.
Yeah,
Let me mention Kaiser Permanente in California, a very impressive integrated healthcare organization that's gone through the 3 shifts, or they didn't call it the 3 shifts. I remember talking to Sharon Levine, who's one of their senior medical leaders, when I went on a visit. We're talking now almost 20 years ago. And Sharon and her colleagues said to me, do you know, in our system, who's the most important member of the healthcare team? It's not the doctor, it's not the nurse, it's not the therapist. It's the person who is seeking care and support. And I said, well, what do you mean, Sharon? What's going on here? She said, well, think about it. If you're one of our patients, and let's say, again, let's use diabetes, it could be COPD, it could be asthma, whatever chronic condition you care to choose, yet you will be in contact with a trained healthcare professional for a very small portion of your time every year. You'll spend most of your time making your own decisions about whether to take your medicines, whether to take exercise, your diet, your social contact with friends and family, all the things we know make a big difference to people's feeling of health and well-being. And
yeah,
those decisions that every person makes are far more important than the one or two decisions that the healthcare team will take in their limited contact with you. So unless we recognize that as a starting point and then make it easy for people to play their part, then we're missing a huge trick. My second very different example, visiting New Zealand, probably a bit earlier than that, talking to people there about their healthcare system, and especially the care and the philosophy within the Maori community in New Zealand. It's a
mm,
much more holistic
mm,
approach. It's much
yeah,
less dependent on the medical model, if I can simplify things. Yeah, health and a feeling of fulfillment comes from the community. It comes from family. It comes from neighbors. It comes from friends. It comes from all those, if you like, non-medical components that are hugely, hugely important. In a way, what I'm trying to say is we have to find our own salvation What works in California may not work in Cardiff. What works in Wellington may not work in Wigan, but we've got our own versions of what I've been talking about because people have been getting on and doing it, whether it's in Frome, whether it's in Wigan, or indeed your own work in Sheffield.
Yeah, no, it's interesting, and I can probably say this as a doctor, but I really wonder whether we've relied too much on the medical model. I don't know what you think, Chris. Do you think we've been seduced by the medical model and all those examples you've described? And this is the same in Alaska with Nuka, wasn't it? Seems to me the commonality is that actually they've embraced that power shift away from the kind of medical, hegemony and lead, doctors and nurses leading towards empowering people and helping them to feel more agency, as you've said. It's very much a power shift, isn't it? And
It
and I
is,
and I don't
yeah,
know
that,
whether.
that makes it difficult too, doesn't it, Ollie? Because if it's a power shift, it means somebody has to be willing to give up power for another
Yeah,
person to be able to exercise power more effectively. And in our system, it means reducing over dependence on the
yeah,
NHS and the teams we are coming into contact with. It means moving away from this more paternalistic model of care. Doctor or nurse knows best. It means moving
yes,
away from, there's a pill for every ill, or a
yeah,
jab
yeah,
for every whatever it might be these days, if we're talking about overweight and obesity. And unless we kind of turn the tide on all of those things, we're going to find it really difficult to move in the direction where we're talking about.
yeah. No, it's fascinating to me that you started with saying that actually until we've sorted out the short term problems like ambulances waiting in A&E, and there's a big obsession there with people having access to GP appointments. I mean, you've walked the corridors of power. You've seen how policymakers and politicians work. Are they going to have to sort those things out before they can get to the stuff that we're agreeing is probably more important and more impactful? How are we going to get past that? We can never quite get there because we're always sorting out the short term problems.
Well, I think that seeing is believing. And I've certainly learned this, in mid-career when we've gone past the formal education stuff. How do we continue to grow and develop whatever the
Mm,
occupation we're in? And certainly in my career, it's the privilege I've had at seeing it firsthand with the evidence of my own eyes, how things are done differently in other
yeah,
parts of this country or indeed in other countries around the world in the way we've been discussing. And I happen to believe, and I may be foolish in this, that our politicians are just the same in that
yeah,
regard. If we can expose them to real world examples where the things we're talking about are being done today with benefit for all concerned, they will take that seriously. I happen to see that I think it was Stephen Kinnock, one of the members of the ministerial team working with Wes Streeting. He went on a visit to Bromley by Bow Medical
mm,
Centre in East London quite early on when he
Sam
became a
Everington.
minister, and he tweeted about it. And he said how
Mm,
impressed he was. Well, what Sam Everington and colleagues in Bromley by Bow have been doing for probably 30 years now is a great
mm,
homegrown example of holistic, community oriented general practice, drawing on social prescribing, going beyond the narrow medical or nursing expertise you can offer people, recognizing the importance of providing advice on accessing income support or housing benefits, giving people access to social prescribing, providing classes in arts or yoga, many, many different examples. And if our ministers can go and visit and see, we don't have to persuade them. They'll be
yeah.
persuaded by the evidence of their own eyes.
Yeah, no, I agree. And we both know David Unwin's work, don't we, over there in Southport? And certainly it's inspired changes in practice in my PCN. We've trained patients to lead education and to demonstrate through their own experience how you can put these things into remission. But I mean, I don't know what your views on this, Chris. I'd sometimes observe, I suppose this sort of approach requires a little bit more involvement from patients, doesn't it? So, I mean, you mentioned the jabs, with the GLP-1 injections. There's something sometimes that perhaps when people are really struggling with life situations where people want a quick fix and they would prefer to take a kind of medical intervention.
Yeah, and this is why I go back to this idea of patient activation and recognizing that
Mm.
people's motivation and interest in being involved and engaged in their own health and care is not evenly distributed across the population.
Yeah.
There are some people who will be naturally motivated, and if they have a recent diagnosis of what they see as a serious condition, that's the trigger for them to behave differently and take care of their health more positively. But not everybody is in that position, and I think we need to be absolutely sensitive to the fact that people with fewer resources, in more deprived circumstances, or whatever the characteristic might be, will need more help and support, perhaps, and more time to be in the position that
Yeah.
we're describing of partnership with the healthcare team than those who have more of those resources. And we need to work with that, but we also need to work on this clinical activation. How do we
Right.
persuade not you, but people like you in other parts of the country who for whom the penny hasn't yet dropped? How do we persuade you that this could help you to do your work more effectively if you have these active patient partners working with you? And they may be a pain in the neck sometimes, but on balance, it's the right thing to do.
Yeah, it's interesting, isn't it? And I'm sure you'll be perhaps with the NHS Assembly been working with the new neighbourhood models. Dr. Manal Bakal, who's been leading that work for NHS England, is talking about one of the 6 key outcomes for these new neighbourhood experiments being activation. Exactly as you say, there's this concept that if people are more engaged in their care, I mean, it goes back to the Derek Wanless word, didn't he? Which I guess would have landed about the time you were in the strategy unit in government. He talked about a fully engaged population, didn't he?
What Wanless argued is if we don't have a fully engaged population, then demand and need for healthcare will continue to rise beyond our ability to fund it through public support, because the public finances are under so much stress. And ultimately, his warning was the NHS may become unaffordable and therefore unsustainable without a fully
Yeah,
engaged population. Now, if you look at the data, that report was in 2002, over the last 23 years, we haven't fully
yeah.
engaged the population. There is some evidence, although health on some measures has been improving, health on other measures has been going backwards. And so his was a prescient warning. We're in the position now that he said we would be if we failed to aspire to that aim. And maybe that's another way of getting the politicians to understand why this is important.
So if I can just kind of clarify that for some of our listeners, so that was a big piece of work. Was it 2002, I think originally it started, wasn't it?
Yeah.
Commissioned by the government at the time, Gordon Brown, Tony Blair, and it demonstrated or predicted that if we didn't get people more involved in their own care, the costs of care and the demand for care would escalate in a way that 20 years later has proven to be true. What do you think we should have learned then, looking back now, 20 years ago? What should we have been doing to I guess maybe perhaps prevent us getting into the situation we're in now, because we are in a bit of a pickle, aren't we? What is there anything you look back and you think, I wish we'd done some things differently?
I think a lot of lip service paid, isn't there, to prevention. That's the kind of the core of all of this. You go back to there was a white paper that Patricia Hewitt published when she was the Wes Streeting equivalent back in 2005, 2006. It was called Our Health, Our Care, Our Say.
Yeah,
And it was sort
yeah,
of like the 10-year health plan of that time. And what did it say? Well, so we need 3 shifts, from treatment to prevention, from hospital to community. We need to embrace new technologies and the possibilities that digital will offer us. And also, it did have some things in there about we need more personalized care. We need to support
yeah.
people to play a bigger part, recognizing their contribution and their agency. Now, if we had followed that through faithfully over the 20 odd years that's passed, it's hard to imagine we wouldn't be in a better position today than we are in today. Our problem is that we have chopping and changing depending on who the health secretary is, which government is in power, what the fashions and the priorities might be, and we don't have enough consistency. It's what Deming, the quality improvement guru, described as the constancy of purpose. And that applies to health plans and health policy as much as anything else. Be clear what your priorities are and follow them through slavishly over 5, 10, 15, 20 years.
Yeah. I mean, that. So I guess what we're sort of saying is it's pretty clear what our purpose should be, to move to this partnership approach, to a shared responsibility. You called it in a paper back in 2018, didn't you? You've been
Yeah.
writing around it a lot. With an optimistic hat on, then, Chris, what's our next steps? Yeah, how is the NHS going to make it happen this time in a way that perhaps it hasn't managed to up to now?
Well, I think you know, Ollie, I'm an enthusiastic amateur cyclist in whatever spare time I can eke out of
Yeah,
my schedule. And I think it was David Brailsford, the guy who used to coach the Sky cycling team, who said, "How do you bring about improvements in cycling?" Well, it's through the aggregation of marginal gains. And that's
yes,
true in every sector of life. There isn't a big breakthrough that will move us from where we are to where we want to be. It's many, many small micro changes everywhere, all at once over time, that will get us from where we are to where we want to be. And that's why I just reiterate the point. Why don't we start local? Why don't we start in every healthcare team, whether it's a GP practice or a hospital-based team, or indeed a team in the community, to take on board patient activation, to recognize the
yeah,
agency of people. Start with the chronic conditions where people are more likely to have a strong personal interest in playing a bigger part in their own healthcare. Start with where there's good evidence that if you do it and you do it well, it really will impact on the outcomes that people experience.
yeah. No, I mean, I love that sort of encouragement there to keep doing it. I think that's really important, Chris. I mean, I'm very conscious at the moment. I mean, I'm a PCNCD. I'm very aware that the policy has changed in the country around the new roles that were set in motion, like health coaches and social prescribing link workers and care coordinators, and we've seen a pullback in investment in those roles
Yeah.
and sort of enthusiasm for those roles, not necessarily because they weren't working, but because people were allowed to spend money now on GPs and practice nurses. And I think the practices sort of feel they've been hard done by for a while and they want to prop up their own services. I don't know, what would you have any advice for people who are hanging in there as health coaches and social prescribing link workers, care coordinators, those person-centered champions? Do you have any advice for them at the moment?
Well, I'd hesitate to give advice to people doing the work other than, yeah, it is the right thing to do. Sometimes you can be on the right side of history and sometimes you'll be on the wrong side of history. But at some point, history catches up with you and gives you the permission and the support to do what you need to do. I think health coaches, as part of a wider healthcare team, can do much of what we've been talking about. Busy GPs, uh, pressurized practice nurses, highly trained professionals often can't do this work because there's so much else going on. That's why having health coaches and people with social prescribing skills within the wider team really matters if we're going to make progress towards this fully engaged scenario.
So basically, you're saying keep going.
Keep going. Don't give up. No, the pessimism of the intellect and the optimism of the will. Not my
Go on.
phrase. It comes from an Italian Marxist called Gramsci. And I think it applies to any area of life you care to think about, whether it's politics or medicine or whatever. We need to recognize that if we think too hard about an issue, we can easily become very pessimistic. But if we sort of stick with where we started in this conversation, why hope and optimism matter, then not everything is possible, but things seem much more likely to happen.
Yes. Yeah. Lovely. Well, I guess you've championed this style of approach for so long, this person centered approach, a preventative approach, a power sharing approach. I'm really relieved to hear that you still think it's valid, even though we've got lots of challenges at the moment. And it sounds to me like your advice to us is just to keep going and that history will catch up with us in the end.
Absolutely right. Yeah, don't be disheartened, Ollie.
We'll keep going, Chris. Thank you, and I really appreciate your ongoing support. You came to our conference last year and joined in the movement. Thank you, and we'll keep your challenge of trying to keep the movement going. Thanks so much, Chris, for your time today.